I'm so sorry, we couldn't hear you guys. Are we audible in the room?
Hello, Assalamu alaikum everybody. I hope we are audible. Okay, so we're going to be starting our cases today. And so from the first cases, this is a 65 years old female. She's been having epigastric pain and vomiting for the past 3 months on and off. She's gotten an ultrasound done that showed dilated duct about 1.7 centimeter with a stone inside. She has a derangement of the liver functions as well. So bilirubin is zero point 0.7 with an alphos of 563. She's AFib.
Can you please keep
over here.
so I'm sorry to interrupt, just keep the microphone sort of closer to you, and if you can speak up a bit.
Okay. Am I audible now?
Yeah, go ahead.
Okay. So this is a 65 years old female. She has come up to us with epigastric pain and vomiting on and off for the past 3 months. She's got an imaging done in which the ultrasound showed a dilated duct of 1.7 with a stone inside. Bilirubin is 0.7 and the alkaline phosphatase is 563. So she is here for ERCP. Thank you.
Okay, fine. Thank you. Tell me, beta. रीमा वो करती है आपके लिए चीजें लॉक कर देती है यार okay good हाँ जी please okay
reporting and missing pathology. And the last thing you want to do is for a 65-year-old who has a, this doesn't sound like context. There's a history of pain. So you are okay. To proceed without balloon in the air. You should confirm.
Okay. Thank you. Well done. Good. Sometimes if you have a difficulty in intubating, so just put them on the side like you did. That's fine. Perfectly acceptable. Achha. यहाँ पे just slow down because what I said to you earlier, you've just got into the stomach. So if you push it, it will come straight into the fundus. Just as Khalid was explaining. So यहाँ पे you follow the rugae. So you follow the rugae and it takes you round towards your right, left, down and right. ठीक है? So that will take you straight to your pylorus like this. ठीक? और यहाँ पे again just look at it and see it as a setting sun. हाँ sunset sign भी है ना, ठीक है ना? ये sunset boulevard है आपका. हाँ जी ये फिर आपको याद रहेगा ना? हाँ ठीक है तो then turn right हाँ right okay हाँ ये आपको हाँ ठीक है that's good तो right oh right okay so that's quite a bulging papilla हाँ ठीक है अच्छा इसको हमेशा कहते हैं ना जैसे खालिद भी एक्सप्लेन कर रहे थे कि beware of the winking papilla आप कहते हैं ना कि this is a piece of cake ना लेकिन ऐसे होता नहीं है मतलब it's always be secondly it's very bulging there's a strong possibility there may be an impacted stone there na they can try to cannulate it through the normal way there's a good chance we'll get in.
At this point in time what are the thoughts that might be going in your mind?
My mind I would still spend quite a bit of time on looking at the papilla because that is important whatever therapy you carry out will depend on because ERCP is all about position and your axis because if your cannula is pointing in this direction and your CBD is going that way you will never be able to cannulate so you have to bring it in the same axis as that and if you look at it take your cannula back now come back with a go push your scope in move your wheels around get a good view of the papilla because you are only getting a part of the view. So you need to see what is beyond there. because that would determine the direction of a cut in case you want to do a pre-cut. See, there's quite a lot to it. So that is what will go through my mind. Okay, how am I going to plan my next move? So never rush into it. Okay, an extra minute or two spent here is time very well spent. So always make sure that you have a good idea in your mind as to where to plan your next move and how to. And secondly, like people sometimes say papillary stenosis, yeah, there is a condition called papillary stenosis, but it is overstated because a lot of the time, as Khalid mentioned earlier, that if bile can come through, your guide wire will go through as well. So it's not a question of it being too tight. It's always a question of getting into the right direction. ठीक है ना? Now you can attempt. ठीक है? Now you got a good wo. So get yourself positioned for it. So now if you see, your cannula is pointing there. That is going up there. So you have to now bring the whole thing into one direction. ठीक है? Yeah. ठीक है? हाँ. अच्छा हाँ सही है. वो क्या कैसे? थोड़ा सा ब्रीम और निकाल दें. हाँ. ठीक है. Try to engage your papilla now. हाँ. And हाँ good. नहीं try to lift it up with it. ठीक है? हाँ. शाबाश. Engage हाँ. थोड़ा सा इसको टर्न करें. हाँ हाँ ये ठीक है. सही है. इसको थोड़ा सा लेफ्ट ये छोटे व्हील को वो कर दें. हाँ लेफ्ट टर्न करें. हाँ देखें ताकि उसको आप अलाइनमेंट ले आए. ठीक है. और हाँ तो वो हाँ वायर स्क्रीन प्लीज वायर एडवांस करें. हाँ ठीक है. हाँ थोड़ा करें रीमा. हाँ आगे तरफ. हाँ वायर एडवांस करें. थोड़ा सा इसको हाँ लिफ्ट करें पे अपने इसको कैन्युला को और लेफ्ट दें. स्क्रीन प्लीज. हाँ नहीं हाँ ज़रा सा. अच्छा हाँ इस वक्त ये कि इट विल बी क्वाइट रीजनेबल. हाँ स्क्रीन प्लीज. हाँ एडवांस. हाँ हाँ स्क्रीन 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 वही. हाँ ठीक है. दैट्स वेल डन. So that's good, right? Okay. So just minor adjustment. देखिए आपने कोई वो नहीं किया. You did an excellent job there. Okay. अच्छा इंजेक्ट करें. हाँ स्क्रीन प्लीज. हाँ हाँ क्या बात. हाँ कीप या हाँ जी या ठीक. थोड़ा सा कैन्युला को बाहर लाए ताकि you can get the lower end of the withdraw your cannula so you can pacify. Keep withdrawing. हाँ keep injecting and keep हाँ जी. स्क्रीन प्लीज. हाँ ठीक. हाँ और फिर और भी लाए नीचे. हाँ टेक अ पिक्चर ऑफ दैट. ओके टेक पिक्चर. आप वो लेते हैं शॉट. ले लें. अच्छा ठीक. हाँ ओके स्टॉप स्क्रीनिंग. अच्छा ठीक है. यू डन एवरीथिंग. ठीक है. अब ये देखें इसमें क्या है. यू कैन सी देयर इज अ क्लियर फिलिंग डिफेक्ट अप देयर एंड देयर इज वन राइट एट द बॉटम. So that was probably preventing you from getting in there. It was impacted. Now you could see it was a bulging papilla, but now it has changed the structure. So you probably displaced, but there is still a stone stuck there. So what's your next plan of action?
I would go for synchrotry.
All right, okay. And again, how would you like? How much would you do?
Till that fold above there, I'll keep around like 50-20%. I'll stay away from that upper fold. Around 15% or 20% of the total length right now.
हाँ बिल्कुल. अच्छा it's always good to make one nice cut.
Straight cut.
हाँ ठीक है ना. So
because the stone is
quite big.
in the ultrasound report and we can see here, it's almost like more than 1 centimeter, 1 point.
Around हाँ बिल्कुल हाँ. You are right. It would be yes yeah. So that's fine. As long as you have an idea, or whenever you are doing a sphincterotomy, make sure that you make a nice clean cut rather than make, cuts go in and zigzag or make a dog's dinner out of it, no?
Do you give a pulse? Do you cut it in a pulse motion or continuous motion?
No, if you ये उस पे है, एंडो कट है, पल्स पे ये होता है कि आप बिल्कुल दबाए रखते हैं, you don't keep on doing, otherwise you disrupt the endocut process. So it's always just press it down while you are doing that. So it will do its own cycle of endo. हाँ बिल्कुल बेटा, तो ठीक है. अच्छा, अब just this is a clever cut knife, right? So this part is insulated. So take this, yeah. Now you can take a bit or more out. So if you got less wire in, you got more control over the cut. ठीक है? And you cut in the direction of the. अच्छा. Secondly, when you pass, you got the cannula in, you can move it in and out to see what the direction of the CBD is. So you are in the right direction now. ठीक है? So you can make a cut there and keep it a bit tight. ठीक है? उसको अपना हाँ 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 इसको थोड़ा सा वो कर दो, वो कर दो हाँ शाबाश. अब हाँ हाँ हाँ. Keep going, 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 keep going. डरना मत. Keep going, 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 keep going. बस. You can cut that fold as well. It's a big stone. हाँ हाँ हाँ. Your cannula is a bit too far in. I would, it's a bit too close and too far in. I think that's a reasonably good cut. You can go further 1 or 2 millimeter. You can do that if you want. You can do more. There's no. थोड़ा सा बाहर करें अपने कैनला को. You are, ये this should be your, no, a bit more out. Yeah, now that's your correct position. Yeah. Yeah. Because your knife is too far in, it will cause damage to the CBD and secondly cause a zipper effect. I think that should be enough. ठीक है सर. हाँ ठीक है. हाँ. You got a good flow of bile there. ठीक है. हाँ हाँ फिर हाँ इसको आप थोड़ा सा कर सकते हैं आप. You can go a bit further, yeah, a bit further, बस इससे ज़्यादा की बात है. That's enough. I think that's enough. हाँ ठीक है. That's a reasonably good cut. हाँ अच्छा हाँ ठीक है. हाँ ठीक है. It's wire exchange. Okay. If you are using a short wire, normally there's a lock here. So you normally lock it there, and she strips the wire for you, so you can handle it. Lekin I still use, I use short wire, but I still use my assistant to handle the wire for me.
So usually your go-to wire is 0.35.
उधर देखिए आपको वो मेरे ख्याल निकल रहा है, आपका वायर निकल रहा है. स्क्रीन प्लीज. स्क्रीन करो भाई. हाँ ठीक है यू आर सिक्योर. ठीक है यू आर वेल. क्या थोड़ा सा निकाल दें क्योंकि विड्रॉ योर वायर अ बिट. यू आर अ बिट टू फार इन. उसमें सिर्फ स्क्रीन करके करें. हाँ विड्रॉ स्क्रीन इतना काफ़ी है. नहीं अब इसको दोबारा से एडजस्ट करें. ऊपर जाएं. हाँ 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 गो फर्दर इन. हाँ हाँ okay, keep screening here. Right, okay, that's fine. Good. Lock. हाँ अच्छा ठीक है. अच्छा, there are, we suspected 2 stones there, right?
Yes.
So start at the mid CBD. हाँ take one take. अगर if you try to take both of them out together, you might be able to get them out, but they can get stuck. So there's no need to do that. ठीक है. Screen please. हाँ जी. बलून आपका किधर है? हाँ ठीक है. थोड़ा सा ऊपर जाएं. Go a bit further up. Further up. Now inflate balloon.
Inflate the balloon.
हाँ
1.2 centimeters.
हाँ हाँ ठीक है.
Done.
हाँ हाँ
And
फिर
coming out
हाँ
and
okay.
pushing the wire in.
Yeah, okay, good, 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 good. अच्छा, ठीक.
So I'm coming.
हाँ, इसमें ये करें कि push the scope in and turn right. हाँ, ठीक है, push in, हाँ, शाबाश. ठीक है,
Deflate, please.
फिर deflate. अच्छा, now go further up. That was clear, right?
Yeah.
So we go further up. अच्छा, दूसरा, what you can do is,
Yes.
because your CBD is now empty,
Yes.
you can always, रीमा इसको वो किया है, प्राइम किया हुआ है कॉन्ट्रास्ट से, कॉन्ट्रास्ट डाल दें ताकि प्राइम अप हो जाए. हाँ, मतलब उसमें ये किस बैलून नहीं इंजेक्ट कर दें ताकि हाँ हाँ पहले इन्फ्लेट करें, इन्फ्लेट बलून, हाँ क्योंकि हाँ देन इंजेक्ट कॉन्ट्रास्ट स्क्रीन प्लीज. और अब आप बैलून थ्रॉल करेंगे, ठीक है. हाँ हाँ ठीक है, इंजेक्ट, हाँ इंजेक्ट, हाँ शाबाश शाबाश करें, हाँ शाबाश की, हाँ कंटिन्यू, हाँ अब हाँ हाँ ठीक, यस या कंटिन्यू या ओके या ओके ओके बैलून खुले ओके. हाँ अब ठीक है. हाँ नाउ पुश योर स्कोप इन एंड राइट उसको टर्न कर दे पूरा, उसको स्कोप को इन करें, पुश स्कोप इन टर्न. हाँ हाँ शाबाश 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 गुड गुड. हाँ हाँ गुड.
Inflated. Balloon inflated.
इन्फ्लेट रखें, ठीक है, इट्स कमिंग आउट, इट वो ज़रा स्कोप, हाँ देयर यू गो. ठीक,
Deflate.
चलो जी मुबारक.
I'm going in.
वसीम, आज इनको तो आपने लंच अच्छा नहीं दिया.
Complete picture.
हाँ डन डन वेरी गुड.
Thank you.
एक और बैलून ट्रॉल करें उसी तरह रीमा वो इंजेक्ट करना. स्क्रीन प्लीज गो राइट टू द टॉप, टॉप तक जाए. हाँ हाँ बस इन्फ्लेट बलून एंड लॉक एंड इंजेक्ट कॉन्ट्रास्ट एज वी कम डाउन. ऐसा ऐसा है, ठीक है. इंजेक्ट ओके. हाँ स्क्रीन, हाँ हाँ ठीक है. हाँ अब आए, अब नीचे आए, नीचे आए, ठीक है. वी आर ऐसा 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 शाबाश गुड 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 गुड. स्टॉप, टेक अ पिक्चर एंड पुल आउट. वेल डन, जबरदस्त.
Deflate all out.
हाँ हाँ ये देखो, अच्छा उस्ताद हो तो कितना अच्छा रहता है. वेल डन, दैट वाज वेरी गुड. ओके ठीक है. जस्ट अनलॉक एंड कम आउट.
Would you want me to stay here and see the?
नहीं, डोंट स्टे हियर, अभी आओ बाहर.
So unlock everything.
अब
Excellent case,
मजा
Ali
पड़
and Dr.
गया.
Bakar.
I think they are asking for.
Excellent case. Very good, Dr. Bakar and Ali. Thank you.
ये
Time out.
Thank you.
65-year-old female.
So are we moving to room 2?
ERCP performed, tracheotomy done, and CBD stone, CBD cleared with extraction done.
So I think the important point was here, if you need to do sphincteroplasty or not, how do you determine that? So we looked at the size of the duct, we looked at the stone morphology. It was a round stone which wasn't bigger than the actual duct caliber, and there was a bulging ampulla or ampullary complex as well. So we felt it should be, and there was only just one stone, not more than maybe two stones, but not more than that. So I think in that situation, we felt it should be easy. Sphincteroplasty probably is not required. Sphincteroplasty when you've got actually size of the stone which is sort of above, so a stone bigger than centimeter, okay, you probably will end up needing it, especially if it's above 15 millimeters, you may end up needing it. More than one stone, okay. So we are in room 2. Okay. And do we, so this is the one they're going to tell us about the history. Okay, so when they're doing the swing double wire, so you actually angle is usually above and lateral towards it. You want to go away from it. Okay, now remember we were talking about forming this loop. We want to avoid this loop. We don't want to form this loop because when we form this loop, look at this. This is the hydrophilic portion of this wire. It's going to fall off very easily. So you don't want to do that. You want to, plus you want to avoid this. This loop is going to cause problems. Okay? So you ideally want to maintain it. And again, not in this direction, you want to maintain in the other direction, away from it. Do you remember that plastering phenomenon that Dr.
अच्छा इस वायरसिंग के हेल्पिंग मिल रही सो आई टेकिंग दिस वन आउट Try. Okay. Now try this.
Tip up, bend this finger toe, and then you bring the whole scope back a bit.
Now can you hear me?
Yes, we can.
Okay, great. So exactly same kind of papilla that we were discussing earlier in the day, that papilla which looks simpler, that is not really as simple as it looks. So there is a long intramural portion of bile duct inside the papilla, and you can see that it's a nice bulge, but we are trying to correlate into the CVD. But every time we try to correlate it, we're going into the pancreatic duct. Although our direction is correct, we can see that we are going in line with the bulge, but somehow we are not able to go inside the bile duct. So we did try to outline the duct, but the contrast went into the pancreatic duct. You can see that there's a nice bile coming. So it all depends on the time and the moment that the wire is going to go into the bile duct. So instead of distorting the papilla, I'm going to pull back, bring it in line with my papillotome, and then once again going to go inside the papilla and trying to put the wire across into the CVD. So can we try again, please? Okay. You see, we're just trying to nudge. So from one angle to the other, we're going to go down. So since it's turning, so that means that I know that I'm going again into the pancreatic side. So maybe some anomaly. Okay, let's try again. Pancreatic. So Eric is telling me that it's every time he tries to push the wire, it goes into the pancreatic duct. Okay, let's try again. So we expect that the CVD opening should be somewhere right here. There should not be any problem going towards the CVD. It's just a matter of chance, maybe luck. So you see, we are again going towards the pancreatic duct. So once I shall like to pull back and going at the top and to this way. Maybe I may try this in this direction. Yes, yes, please try. Okay, still not going in. So pull back maybe just with the guide wire, please. Okay, push the guide wire, please. So this is what the doctor said early in the day, engagement in the papilla going slightly inside and then trying to push the wire across towards the CVD. I think I'm still in the pancreatic duct. It's going round into the pancreatic duct. So if I can push further up into the pancreatic duct, so please push inside the papilla. Push inside. Yes. Make a loop. I think we're going into the branch duct, so that's not the right way to do. Let's pull back. Pull back the wire and yes. Now please try again. Hmm. Okay, let's try now. Now papilla, which looks very simple, very straightforward, at times can become challenging. And what I gathered from this, possibly there may be a structure at the bottom end because on ears there are the stones. So let's try to push the wire across into the. No, I like to go into the pancreatic duct. So I like to leave the wire in the pancreatic duct since we have gone into pancreatic duct quite a few times. So let's try doing it. So push the wire, please. Yes. Go around. Keep going, keep going. So let me follow with the cannula into the pancreatic duct. Okay. Okay. Now try to push. Now we're going in the wrong direction. I need to go into the main pancreatic duct. So okay. Now try it, please. Guide को लेके जाए. Push the wire. Yes. Yes. It's a nice one. Good. Okay. Now let me follow it again. Let me follow. Yeah, follow. Yeah, go. Keep pushing. Keep pushing. Keep pushing. Yes, keep pushing. Yes, push. Push. No, we're going to the wrong side. Yes, branch duct. No. So once again, push. Yes, push. Yes. Now, stop. Let me follow the cannula. Okay. Okay. Try please. Now we're going to the. Now push the wire please. Push the wire please. Now. Okay, let's keep the wire here. Slight push. Yes. Now hold it there. Keep it there please. Keep it there. Okay. So what I'm going to do is that I'm going to maintain it as an anchor. I know this is not the most stable position of the pancreatic duct wire. Generally, I like to take it all the way towards the tail. There. Now this position looks little different from the previous one. So what I'll ask Eric is to just pull up the papilla, pull up the papillotome to have a different direction. Yes. Now pull up please. And now at this point to push the wire. Are we going in a better position or still the same? No, we're still the same. Okay. Now please try. Hmm. Okay. Now please try. Maybe we have a structure down there. Okay, I think it's a little better direction, but yes, okay, let's try now. Huh? Are we in a better direction or still? No, we're in the pancreatic duct again. So possibly we have a stricture at the lower end of the CVD. What does the EOS say or MRCP say? Does it have a stricture? Okay, right. So let's try now. Okay. Okay. But unfortunately, we're not able to go inside the papilla. We can see the bile. We can see the. Okay, let's try now. Okay. जी पीडी क्यों लेट हो गई तो it's going again it's going into the PD again and again. Now let's try again, please. Hmm. I know we are into the PD once again. So try
Sir, I'm sorry
try
to interrupt.
now.
We are going to switch to room 2. Is that
Okay.
1? Sorry.
Try now, please. अब देखें.
So I'm really sorry to interrupt. If you're audible in the room, we're going to switch to room 1 for now, please.
हाँ स्टैंड के ऊपर से काट लेती थी. Try. अब देखो. अब किधर गए? नहीं, it's okay. Eric. उन देख. उन देख भाई. नहीं? अब देखो. अच्छा. I'm doing all the right maneuvers to go into the CVD, but definitely that means that there's some kind of structure. So I'm doing all the right things. So this happens at times. So nothing bad about it. Don't feel bad कि ये हो नहीं रहा. So all you can do is that you can do the right maneuvers. So we are doing the right maneuvers. Okay, we're going into papilla again and again. Now we have a choice that either we can put in a pancreatic stent and cut over, or we can over time if it's not gone in, or
Dr.
You see,
Hassan, we are with you.
cutting over the stents. Okay, now try.
Okay. Can Nadeem, can you hear me?
Gee, yes, we can.
Okay. So I was just going to show the scope holding. I'm sure it's been gone through before too in the other rooms. Can you see me, my scope?
Yes, we can, yeah.
Okay. Uh, I usually hold the scope at close to 25. And if you look at the, as I mentioned earlier in my presentation, if you look at the scope itself, the lens at the end of the scope is almost 1.5 centimeter, end of the scope 1.5 centimeter beyond the camera. The upper esophageal sphincter usually is at 17, 16, 17, 18 centimeter from the incisor. If you hold the scope like, let's suppose at 15 or 16, 17, by the time you get to the upper esophageal sphincter, you have to move your hand back to hold the scope to move through that. So that can irritate the patient, especially if they're not intubated and you kind of lose the control. If you're holding too far back, like at 35 or 40, that could be problem because then you don't have a control of the scope. So what I usually do is I hold close to 25, and that's with every single scope without even thinking about it. My hand just goes straight to the close to 25. For ERCP scope and for that matter EGD scope too, usually people go over the tongue like this. What I do is, you don't have to do it, but I personally do it. I make it like a oral airway, upside down like on karna zara? Upside down like this. You see that? Go like that. Instead of most people go up like here, go over the tongue right there. But what I do is I flip upside down. Okay? Can I मुझे दिखाना जरा lube? इसके पीछे लगा दिया? लगा दो और okay? ठीक. So what I'll do is I'll make a scope like that, like an oral airway, go above the tongue. When I hit the back of the throat, I'm hitting there, and I flip my scope there. What that does is that will take me straight to the oropharyngeal area, and usually इसको थोड़ा सा जो है ना bend कर दो, neck को flex कर दो. अब बहुत ज़्यादा extend किया हुआ, हाँ बिल्कुल. थोड़ा सा lift. And if it's giving a trouble getting in there, you can always lift the shoulder, and that would help you get in easier relatively. There you see that gently, just lifting the shoulder up a little bit will take you in. Ajo up, okay. And when you are holding the scope, yes, right there, all wheels unlocked. Stay away from the patient, like that, and scope is like there, right there, okay. Gently going in, chalte jaye, chalte jaye, chalte jaye. Keep going, keep going. You're going to get to the GE junction, okay, which is close to 40, as you said, depends on the age. So you see the change in mucosa right there. Now big wheel away from you, okay, and rotate the scope the way I said, like, no, unfreeze, okay, like there. You see that? You see the gastric force now. You're right there, and then facing the towards the patient wheel. You see that? Big wheel towards you now, a little bit. Big wheel towards you. Okay. So it's a little bit, it's going to be right now. You see that how it retroflexed? So what? No. Calm down, calm down. Okay. Don't need to push because that's just going to make a fold. So you need to pull the scope back. Now flip the scope and then gently advance. You see that how it becomes very easy, because if you keep pushing, it's going to keep making a U-turn. So the way you were, if you have kept pushing, it's going to keep folding into the stomach. So you have to pull the scope to guide it. So we're going to go back right there, okay? Right there. Wheels are facing up. Rotate to the left, inflate, insufflate, insufflate. Okay, so let's go, big wheel towards you a little bit. Okay, right there, right? If you keep pushing, it's going to retroflex. You see that? Okay, so you need to pull the scope back and then flip. Make sense? Okay, good. So now gently advance. No need to do too much there. Gently advance. Suction the air. Suction just a little bit. And now we're close to the antrum. So what we'll do is we'll come back, big wheel away from you a little bit. What we're doing, we're trying to see where the antrum is. Right there, right? Okay, so straight, big wheel towards you. So no, now hold on. It will go in because you are able to adjust a little bit, but you should have a big wheel towards you couple of centimeter before that, like right here, big wheel towards you. We know it's right there. Now stop there. We are into the duodenal bulb, right? Insufflate. Okay, and suction. Right there is the duodenal apex right there. That's what I was talking, okay? Big wheel towards you a little bit, okay? Little bit. You see that how gently, big wheel, you're trying to look at the medial wall because if you're looking at the lumen, your scope is not gonna go because that means your scope is hitting the back wall. So it's a side view scope. You should not be seeing, you may be able to see a little bit of the lumen, but you should not be seeing more than that. You see that? Nice, gentle. Go beyond that. So once you're right there, stop there. Now small wheel away from you. Here you can lock it if you want to, but many times you don't have to. I don't lock it. So suction everything just for a second. Rotate the scope to the right and then start gently pulling while rotating. Right there. Suction everything now. We're right at the papilla. Okay, good. Okay, so now we're going to stand there. Suction all the bubbles, collapse it. All set it up. Just collapse it. And no need to do too much movements. You are very stable right here. Suction everything. Suction. No, all the way suction. Suction karo. Yeah. Collapse karo lumen ko. Just collapse it. Collapse. Keep it going. No, don't. Just completely collapse. Suction ke upar. Just press the suction. Completely press it. Keep it pressed. Okay. 1 minute ka na. So right there, okay. Now insufflate it. I'm trying to get rid of all those air bubbles. Okay. So just, and always try to keep the scope straight. Insufflate a little bit, okay. So we can get that into the right position. Right there, dedo, cannula, tome. We'll use the tome. And before we touch that papilla, we're going to talk about the papilla, what kind of papilla it is, okay? And the scope should stay right there. Okay. What's the lelo up? You can grab it. Okay. Keep going, keep going. Or elevator should be locked when you are pushing. Yeah, good job. Good. ये फ्लोरो किधर है? ये वाला है? या अभी हाँ पोजीशन को सेट करेंगे अभी थोड़ा सा 1 मिनट दिखाना मुझे मैं आपको देता हूँ 1 मिनट सो ये देखें इस तरफ you're standing right there wheels facing towards you ठीक है I'm gonna collapse all that so we can just get rid of all the suction all the bubble air bubble okay so right here ये हमने लॉक किया हुआ है याद है आपको मैंने कहा था कि I don't lock yeah so that gives me a better control if we look at this I didn't know I will let you cannulate okay don't worry about it I'm just gonna how the to study the papilla okay right here this is my tome this is my orifice right there this is the first fold of the papilla that's the fold of the papilla there so yeah where the papilla meets the actually that's here this is the direction right there you see from here we'll go straight it's a little bit curve we have to make but should be able to make that here so now this position is very stable position look at that duodenum is not moving we haven't given anything to the patient no atropine no buscopan but it's a very stable so right here a little bit even on the fluoro you look see that duodenal lumen is quite bigger as compared to the normal but we have to get underneath the papilla papilla right there. Okay, I think here, right there to cannulate it. Okay, Ajo. And we're gonna keep looking at, keep facing your chest and shoulder. Yeah, that's good right there. Yep, that's. I'll put it on the other side, back side. So, and if you want some to hold him to hold the scope, he will hold it for you there. So instead of doing too much this way, do it this way. So this is better angle for your bile duct cannulation. Okay, wire देना थोड़ी सी. We're gonna use the wire tip. Do you remember the way we were used there? I showed the videos right there. Relax, 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 relax. Good. So I'm gonna help you. You see that? No, no, gentle movements, slow movements, like that, and your scope should move. See that? Okay. So we will push the scope in a little bit. Big wheel a little bit towards you. Right there. Okay. Now it's nicely engaged there. Okay. Gently advance the tome there. Gently advance the tome. Okay, you should be already in there. Yeah, look at your wire is already cannulated. When your angle is right, it will go in. नहीं नहीं आप relax करो. आप you are very stiff, very intense. Okay, small way, gently. Let him go in. No, good. आप advance करो tome को. Big wheel towards you. There you go. Pull the scope back a little bit. Angle is correct. Everything is correct. Just smoothly maintain. Okay. Inject करना ज़रा आप. Okay. हाँ जी. Yeah, that's a PD. Okay. हाँ, it's okay. PD है ना. हाँ, okay, that's okay. All good. Okay, so that's a lot of injection in there. Even though it looked like it's going into the bile duct, it looks still a PD है. तो ये okay, yeah. Inject कर. हाँ, PD लग रहा था. Okay. एक मिनट ठहर जाओ. I still don't see the branches, but I don't see the hilum either. Okay. Yeah. Go in. एक मिनट दिखाना सर. Okay. हाँ? हाँ जी करो. Flora. इंजेक्ट करो सर. इंजेक्ट करो थोड़ा. हाँ कर लो. जो हमने थोड़ा इंजेक्ट कर रखे. ओके. हाँ that's a PD. ठीक है. I don't use side branches. अब आना है. ठीक है. चल that's okay. Let's come back. Try again. Okay. It looked like it going in the direction of the bile duct. So we will do that. Okay. So just follow the instructions now. Okay. Engage that with the tip of the wire. Okay. Right there. Stop there. Go in a little bit. Okay. Stop there. Okay. Big wheel towards you now. Okay. Flora. Now go. आप देखें कैसे गए हम उसका हमने पैनिक नहीं हुए. That's number one thing. ठीक है. And we changed the trajectory just a little bit and kept the wire of the tip very high up there where the orifice is towards the upper border. ठीक है. And change the direction a little bit to the left by big wheel towards you and lifting it up with the elevator. ठीक है. तो हाँ जी. Go ahead. So yeah, that's a big stone there. Oh, honey. Canal अंदर ले जाओ. Tom inside the Tom को push करो. Tom को push करो. Tom को push करो. Big wheel towards you. Okay, okay. In big wheel to elevator. Big elevator up. Good. There you go. Okay. Inject करो आप. Okay. Oh, those are big stones. Okay, so that's going to be challenging for today. Okay, and any question about the cannulation, Nadeem?
Again?
we're done.
We are just enjoying your techniques of teaching and all the tips. So
Okay.
it's
These stones are quite big. This may take a little bit time. One option is we take care of the smaller stones, स्टैंड डाल दें और फिर वापस ले आएं या आज करना है कि हाँ, this will be a good case for EHL. I don't think either it's gonna need some sort of lithotripsy, be it mechanical or EHL. So Wasim is saying like let's take care of the smaller ones today, put a stent in there, and we can bring back for EHL some other time.
Yeah.
Okay. So now what we'll do is we're gonna exchange. He's gonna push the wire in, and you're gonna pull the tome out.
So just one quick question,
That's what
Dr. Hassan, if that's okay.
If it needs to come back. Huh? G?
Just a quick question. So initially, when we cannulated PD, the
Yes.
wire had actually crossed the scope. So it initially gave the impression as if you were in the right duct.
Correct.
And so you know that understanding that once the wire has crossed the scope, that obviously this case beautifully demonstrates that you still have to keep an open.
You
open
have to
mind.
be, yeah, exactly. And other thing was like when we went in there, it's a good sized duct diameter of the PD as well. And it looked like there was no side branches visible in the beginning, but you don't see the hilum either. And it's crossing the crossing the spine as well. So I was wondering, is it really a bile duct or a PD? That's why we pulled the wire back, brought the tome right at the orifice, injected again, and then you saw the side branches. Then you know that it's in the PD. So the option would have been just put the wire in there, use a double wire, or come out completely because it's draining nicely, no problem. So we decided to pull it out and give it a try by attempting one more time for the bile duct, and with one touch it was again into the bile duct. If I had it gone back into the PD, then I definitely would have taken the PD and probably either do a double wire or put a stent in the PD and then go after the bile duct. चलो टोम को थोड़ा सा और पुट करो बाहर, थोड़ा सा और. Okay, इसको जरा बो करो थोड़ा सा. Okay, so it's okay. So you see that, hold on, no, don't move too much. So this is a clever cut wire, what we call, clever cut tome. Half of that cutting wire is covered by the plastic sheet, so that is not gonna cut. The distal half is the cutting wire. The way I do it, I don't count the covered part. What I do is I count the uncovered part of the wire, okay? I'm gonna pull it out a little bit. इसको छोड़ दो मेरा भाई. और मैं जब जिस चीज़ को कर रहा हूँ तो आप छोड़ दो उसको 1 मिनट के लिए. So I want to show you something, ठीक है? You see where the cutting wire starts, where that sheath is, and to the end, you're gonna put 1/3 of the cutting wire inside the papilla and 2/3 out. Okay, let's do that. Go in. Okay, and stop there for a second. So one other thing I will show you guys is with this tome, sometimes if your angle of cut is same, the angle of axis of cannulation is going to be the same direction what was the axis of cannulation. So if I bow this wire, it will go a little bit to the right. If I unbow and unbow excessively, it goes to the left. And just gently straighten it so I can stay in one place. Sometimes if it is to the left, you can actually unbow and that would change your angle of a cut. So here, the way you're going to control the cut is not with the tome, with your scope, okay? Tome, with your scope. Hold the scope. Big wheel a little bit toward. No. Rotate करने की जरूरत ही नहीं है. Just hold it. Just hold it, okay? Big wheel towards you a little bit. Okay? Big wheel further. No, मेरा भाई इसको नहीं करो अभी. I keep telling you same thing over and over. नहीं करना अभी उसको. देखे कुछ करने की जरूरत नहीं है. Relax. Just hold the scope. Big wheel towards you. Okay. You see that how much it goes in? Okay. So big wheel away from you. अभी हमने नहीं काटना, ठीक है? I'm just showing that moves. Okay. So we'll pull this back a little bit. Okay. Big wheel towards you. Okay. I'm going to push the scope in. Now Ready for cut? I will cut. You want to cut it? Okay. Yellow paddle. Okay. So टैप करना है, ठीक है? ज़्यादा उसके ऊपर बैठना नहीं है. नहीं, अभी मैं कहूँगा जब when I tell you, then you are gonna do. Okay? Here we are dealing with a real patient, so it's my responsibility and your responsibility. So to relax, we're gonna do it together. Okay? Big wheel towards you a little bit. Okay. Now cut a little bit. Good. Big wheel. No. Stop. One tap. Okay. Let it rotate to the left or to the right. I mean. Okay. Go for it. Go. Go. Cut it. Cut. One more. One more. One more. One more. One more. Slow. Go. No. Stay there. Go. Go. Okay. Okay. Go. Pull it out. Your tome is way too much in there. That's why. Pull the tome out a little bit. Okay. Right there. One more cut. That's it. Okay. Ji? Both. It's okay. Okay. So that's a lot of, that's a good sphincterotomy. We cut the sphincter basically completely. There's no sphincter left. There's a little bit bleeding. That should stop on its own. I don't see anything major, but you see a nice duct there. So I don't think we need to even do a sphincteroplasty for these smaller stones. So exchange karo. And always coordinate with your technician. Lock karo wire ko. Okay. Okay. Or need to look there. There's no need to look here. Okay. Keep an eye on the wire. Balloon दे दो और फिर I think they give me a double pigtail stent डाल देते हैं, ठीक है? 10-7 या 10-8 नहीं है? 10-9. डबल pigtail चाहिए तो 10-5 ही है but 7 नहीं है. No, I mean 10-7 नहीं है double pigtail. 10-10 both even that should be fine, but 10-5 is fine too. ठीक है, जो भी है. Okay. पहले extraction balloon दे दो. Okay. ठीक है. Okay. फिर हम we're gonna we have 3 more minutes. We're gonna go ahead and remove these small stones which are at the bottom, and then I'll put a double pigtail stent in there.
Perfect.
Jordan. Okay. Nadeem, any question? We'll just remove the stones which are at the bottom, ठीक है? छोटे वाले दोनों, okay? So one stone at a time. You don't want to do too much. Balloon किधर है?
So
okay, inject करो थोड़ा सा.
So Dr. Hassan, just talk us through your decision-making sphincteroplasty as opposed to cholangioscopy and EHL when you see those massive filling defects.
So in this case, if I was going to go ahead and do if I plan to take care of the stones, and then I will, in this case, the sphincterotomy itself is pretty big enough, but you can do a sphincteroplasty further because the duct itself, if you look at the shaft of the scope, which is close to 13.5 millimeter for the ERCP scope. Stones are quite big, and the duct itself is close to literally 20 millimeter or so, 2 centimeter or so. So you can do a 15 easy sphincteroplasty, but these stones are still not going to come out, and they're going to require some sort of lithotripsy. So just in interest of the time, we're going to just do remove those small stones. For that, I don't think we need a sphincteroplasty. And balloon up ke hai? Okay, go ahead. Up करो. Okay, balloon up. ठीक है. अब pull करो balloon को. Okay, just balloon. नहीं, injection की जरूरत नहीं. I mean, floor की जरूरत नहीं. Pull the balloon. Pull, 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 pull further. Pull, pull, pull. Okay. Okay. So I think it's there you go. Okay. So can I show them? You give me. So when you do sweep, still bleeding. Okay. So I think it should be okay. It's not gonna be. I think it'll get better. Yeah, it's a bit bleeding, but that should get better. Okay. Inject करना है जरा. जी. हाँ लगवा दो. Balloon zara. Okay. Balloon up. Okay. Okay. So you see the balloon, there is no major stone at the bottom. What I'm going to show is like how to do a balloon sweep, because if balloon is giving a trouble, it wasn't coming out initially because the stone was underneath the balloon. Stone, it looked like those stones two were together, so giving a little bit difficulty. So the way you do a balloon sweep is you see how the scope is crossing the bile duct and the balloon is going like up like that. So it's making a figure of 8. Can you imagine that figure of 8? So balloon up. Balloon is up. Let's imagine that stone is between that balloon and the scope right now. So I will move the big wheel of the scope towards me and then gently advance the scope and rotate to the right. You see that how it comes out easily, that balloon? And from there, what I'll do is pull the scope back, and the meanwhile, Wasim already has deflated that balloon. So I don't lose my position. Okay? So balloon inside, it was right here. Balloon एक दफा दोबारा करना. Okay. Right there, that's the position. I will pull the balloon down. Stone is between the balloon and the scope and holding the balloon with my fingers right there, rotating the scope, pushing the scope in and rotating to the right. And it like balloon and the scope, they move together as an assembly downward towards the third part of the duodenum. And rotating the scope right pulls the stone out. And then as soon as the balloon comes out, Wasim will deflate that balloon. And I just pull the scope back and that would take me straight back there. Okay? इसके ऊपर लगवा दो कुछ. Okay? हाँ? That's good. हाँ, इंजेक्शन लगवा दो. हाँ, पहले स्टेंट डाल लें, फिर उसके बाद हम इंजेक्शन. जी. डबल पिगटेल. हाँ जी. Okay. We're going to go ahead and put a stent, and then we may do a epi injection there for the bleeding. But I think it's going to stop eventually. It's slowing down. Okay. And usually, if you still have a continued concern, what we usually do is we put a fully covered metal stent in these. Let's just put a stent, a double pigtail, and I think epi should be fine. Okay. इसका मार्क किया हुआ है टेल को, आउटर वाली या डुअल मार्कर? ठीक है. आ जाओ. ओके. नो, पहले इंट्रोड्यूस है. Push that in. Good. Okay. Okay, rotate a little bit to the right. Okay, that's good. And push the scope in so you don't fall back. Yeah, gently keep going in. Introducer is there right now. Good. Keep going. Keep going. Okay. हाँ जी चाहिए मैं कर रहा हूँ ओके अब वो इंट्रोड्यूसर वहाँ पे पहुँच गया ऊपर ठीक है ना यू सी दैट ब्लैक मार्क राइट देयर इट्स वेरी हाई अप देयर ठीक है थोड़ा सा इसको पुल कर थोड़ा सा वापस करो सर हाँ ताकि देख लो मैं I'm just want to show you that you see that where the transducer is inside that black mark and जो है इसका जहाँ पे जो डक्ट्स जो दो नज़र आ रही हैं थोड़ा सा पुश करो अंदर push karo. You see that black mark of that transducer on the x-ray? Yes. Okay. So what he's going to do is he's going to unlock that, ठीक है? और ये he will pull on it, give a traction, keep that black mark there so you can advance the stent over the introducer. ठीक है? So stent is going to slide over the introducer. Only way it's going to slide is if he gives a traction and you push the stent over that and that black mark stays there. So that means it's holding there while you're sliding the stent over that. ठीक है? Okay, ready? Okay. So उसने unlock कर दिया. Let's go ahead and push that now. Stent over there. वो देख रहे हो black mark उधर ही रह रहा है. It's not moving while you're. Okay, keep going, keep going. Good. Keep going, keep sliding, keep sliding. Good job. Keep going, keep going, keep going, keep going. Good. जब ब्लैक मार्क ऊपर वाला स्टेंट का आएगा ना बाहर वाला तो स्टॉप दे या दिस इज द फर्स्ट मार्कर ठीक है देयर इज एन अदर मार्कर कीप गोइंग इन सो दैट्स द इनर टेल okay the external tail does not come yet that's the second one right okay just the elevator stop there so what I'm gonna ask him is make a loop inside one first ठीक है हाँ जी थोड़ा सा loop बना दो okay so he's pulling the wire and the introducer out so once that is made I will ask him pull a little bit more thoda sa aur pull karo okay okay pull karo thoda sa aur okay stop kar so now we will just push it in a little bit rotate to the right here release the elevator let the elevator go no yeah completely open the elevator and push it out. Yeah, you push it out. It will not go in. Don't use the elevator. It will not go in. It's just going to come out of the scope. ठीक है? आप pull कर लो आप. कर दिया? Okay, push कर. There you go. So you really don't have to do too much movement. Bring that lower part of the introducer into the stent at the lower part and then just release the elevator, rotate to the right, push it and then ask him to pull everything out and the tail will come out. ठीक है? अब let me take a look. Good, good job. तो वो तो बंद हो रहा है. एक मिनट मुझे दे दो वो. हाँ हम इंजेक्ट कर दें. It's much slowed down much better. कर देते हैं ताकि वो. Yeah, it's just a little. Yeah, it's just. It'll come. Any questions, guys? We're going to do just a little bit injection of epinephrine. And I think it's already stopping, so you should be fine. It's not going to be a problem.
No, I agree. I think the room, we all seem to agree that probably is the right thing to do.
No, it's in the right place. It's a 5 centimeter only. For 5 था ना? हाँ, तो छोटा है ना stent. पहले तो tail थी. Now it's forming the inner tail. ठीक हो गया वो. अब तो चलो थोड़ा सा needle लगा दो. Needle दे दो मुझे. So for needle injection, I don't know if you realize that if I have used the elevator and he pushes the needle, it's gonna get hung up into the scope. So what I did is I released my elevator. I don't see the needle, but I know it's outside. It's not inside the scope. and I asked him push the needle out. So he did that. Now I can use elevator and see my needle. So otherwise needle does not come out of the catheter if you're using an elevator. So we'll just inject right on the, usually the bleeding is on the tip, but not always, but we will go ahead and inject right there. G. एक और कर दो. कर दिया? There you go. बस needle out. Okay. So that should take care of it. अब खत्म हो गया वैसे भी. Bleeding वैसे ही रुक गई है. Okay. So before we finish the case, I want to show how to remove the scope. So what you do is make sure all of your wheels, elevator are unlocked. Pull the scope, take a picture of what you did, and I will suction this all junk from there. I'm happy. I don't think it's going to be a more active bleeding. So from there, gently pull the scope back into the stomach. Once it's in the stomach, do the same maneuver, which was rotating to the left. You remember that? Okay. Once you are there, then suction all the fluid out of the stomach. अब देखना उसके, you see that how decompressed my stomach is? No air whatsoever in there. Okay, so I'll pull back a little bit further, suction all that junk, and look at the scope, how I'm rotating downwards to get into the fundus and suction from the body. All the wheels are unlocked, by the way. There's no lock on the wheel. Once I'm done with the suction, I would keep my fingers off the buttons, so I don't want to put any more air in there. Make sure my wheels are in neutral position. Once they are in neutral position, I'll use a little bit suction, pull the scope out. Scope needs to come out straight. It shouldn't be like that. If your wheels are not in neutral position, scope will be bent at the end. So just gotta make sure suction everything out of the stomach, pull the scope straight out. Question?
Just one. That's fine, sorry.
Okay. I think I will come over there happy to answer any questions. Thank you.
Yeah, no.